My name is Sheahan. I'm a senior dietitian at Cork University Hospital, where I work with both surgery and critical care. My areas of interest are perioperative nutrition and intestinal failure. So the title of my poster today is The Incidence of Malnutrition Risk in an Elective and Emergency Surgical Cohort, a snapshot within an Irish hospital. So to give a bit of background, perioperative malnutrition is associated with a fourfold greater risk of mortality, greater odds of complications, prolonged hospital stay, and increased hospital costs. So the aim of this study was to identify the incidence of malnutrition risk in both elective and emergency surgical patients. So the method, this one-day observational study was carried out on a 70-bedded surgical unit. A validated screening tool, which is the MUST tool, which was developed by EBPOM, was used to screen for malnutrition risk. 3 parameters are used within this tool: the body mass index, percentage weight loss over previous 3 to 6 month period, and also if the patient is acutely unwell and they are unlikely or have not had nutritional intake for greater than 5 days. This screening tool, it identifies malnutrition risk. It does not identify nutrition-related mortality risks. A series of data was also collected within the study: surgical specialty, diagnosis, gender, age, length of stay, and if the patient was under the care of the dietetic service. So to look at the results then, 42 out of 70 patients consented to participate in the study. The breakdown of those patients, 47% were emergency services, 26% were under colorectal services, 14% were under vascular, 7% were under breast, and 4% were under hepatobiliary services at the time of the study. So if we look at the results of the breakdown of malnutrition risk, we can see that looking at the emergency patients, 55% of the emergency patients were at risk of malnutrition because they had a MUST score of greater than 2. 64% of the colorectal patients were at malnutrition risk, and 50% of the vascular patients were at risk of malnutrition. Interestingly, within the study, 33% of those enrolled had cancer, and 42% of this cohort had a MUST score greater than 2. If we look at the second figure, the malnutrition risk by age, we can see with increasing age, there was an increasing risk of malnutrition. And this is similar to a study which was carried out by McGuinney in 2018, where they found age was an independent risk factor for malnutrition risk. So to conclude, this study demonstrates the high incidence of malnutrition risk in both elective and emergency gastrointestinal surgery patients, and the incidence of malnutrition risk in our Irish cohort is similar to the results found in other international studies. Thank you.
Thank you very much indeed. And our next poster, I think, is Karam and Manpreet.
Hello everyone, this is Dr. Manpreet. I'm one of the clinical fellow working in Department of Anaesthesia in London Northwest University. Today I will be presenting a poster on Sugammadex usage and awareness about the readministration of rocuronium after Sugammadex. Sugammadex is a gamma cyclodextrin which is highly effective for the reversal of neuromuscular blockade induced by rocuronium. Patient may require anesthesia and tracheal intubation, especially immediately post-op period, then and immediately after reversal of rocuronium by Sugammadex. So in that case, we have an option. For example, if we have given Sugammadex 4 mg per kg, and if we need to reverse it within 5 minutes, we need to give rocuronium of 1.2 mg per kg. And if we need to reverse within 4 hours, then we need to give a lower dose, which is 0.6 mg per kg. The onset may be prolonged to 4 minutes, and duration may be shortened up to 15 minutes after re-administration of rocuronium, which is 1.2 mg per kg within 30 minutes after Sugammadex administration. So re-administration of rocuronium after immediate reversal, that is, if you have given a dose of 16 mg per kg, then waiting time is of at least 24 hours. So we explored the knowledge of the anesthetist about the re-administration of rocuronium after reversal of by Sugammadex. So we had a questionnaires which were presented to 26 anesthetists belonging to various grades, from SHOs to specialty grade to specialty registrars, staff grades, and consultants in our hospital. And questions explore the Sugammadex usage and the knowledge about the re-administration of rocuronium after Sugammadex. Correct answer was being quoted as yes or no, and if not, then it is not applicable. Rest of the poster would be presented by my colleague, Dr. Karam, and it over to you.
Yeah, thank you, Manpreet. So coming on to the results, So we had a response rate of 100%, 26 anesthetists, all of them have given the response. So from the response, the Sugammadex usage was fairly common. Most commonly, they were using in difficult airways. And 1/3 of the anesthetists, like almost 31%, were not aware of whether rocuronium can be given after the Sugammadex. So, and maximum anesthetics were not aware of waiting time and dosage of rocuronium that can be given. Almost for 4 milligram per kg Sugammadex, they were 70%, they were not knowing about the waiting hour, and 16 mg per kg Sugammadex, they were not knowing about in 50%, and dosage also they were not knowing. So we after this having and results, the participant anesthetics were informed about the dosage and waiting time for the rocuronium after the Sugammadex, and this was planned to present in our clinical governance meeting, and we prepared a leaflet about the dosage of rocuronium and timing that can be given after the Sugammadex if the patient is coming for immediately after surgery and given a Sugammadex for any emergency surgeries. And so further knowledge and educations are necessary for all the anesthetics for the usage of rocuronium and another neuromuscular blockade after the reversal with Sugammadex. Yeah, thank you.
Thank you both. Well done. So next up is Rona, I believe.
Good morning. My name is Rona Sinclair. I'm an anaesthetist in the northeast of England, and I also work with the POM-CTN, which is the Perioperative Medicine Clinical Trials Network. I'd like to take the opportunity to present some of this work, which is some exploratory work looking at the use and the management of anemia after hip fracture. The reason that we've put this together is because we're interested in studying this as a larger research project in the future. And there are some questions about whether the use of intravenous iron in this group of patients may be beneficial or may not be, depending upon which studies you read. So this was designed to be a snapshot of usual practice and to explore ideas, opinions, local guidance about treating anemia in this type of patient. The way that we conducted this was with an anonymous online survey. So we used Smart Survey, and it was done between February and March of this year. It was drawn to a rapid conclusion when everybody's inboxes and clinical work became orientated around coronavirus. But nonetheless, we managed to get 277 responses before the survey was closed due to a complete drop-off in response rate. So these people were a group of anaesthetists, geriatricians, surgeons. They covered at least 81 of the UK hospitals, though a number of people didn't state where they were based. And the main responses were to find out about whether they used guidelines, whether those be local guidelines or ERAS guidelines to look at anemia in this group of patients. 29% of responders did report the use of local guidelines to manage anemia. A third did not, and a third didn't know whether they had local guidelines or not, which is telling in its own right. The majority of this guidance pertained to the use of blood products, and in fact, when we dived deeper into it, you can see that actually it was mainly blood products that were being used and that people weren't considering other treatments for anemia in the same way. We are particularly interested in the role of intravenous iron in this, and only 6.3% of those that responded suggested that intravenous iron was used regularly within a clinical guideline, which may be what you expect from this population. Interestingly, however, a further 40% said that they would use it on an individual basis for this type of patient, which suggests that it is in use and people are starting to use this despite there being a paucity of evidence to support this. We explored why people were and were not using intravenous iron. The scope of the poster is smaller than we can present all of this data, but in essence, people said that the reasons they weren't using this product were because of a lack of evidence, because of lack of local guidance, and perceived low efficacy, I think, was the other thing that came out in the survey. given that this is something we'd like to research, we asked for comments about future research, and we asked people whether they agreed whether it was an important research topic and something that they would like to see more research available in. There was an overwhelming response that 92% of clinicians agreed this was a useful topic for further investigation, and that most of those were prepared or would be prepared to recruit patients into a study in this area. Given the comments there, I think there is interest in this, that people feel there is a need for large randomized controlled trials to look into this type of work in this group of emergency patients. And that heralds our conclusion that there is a varying amount of work going on in this area, and that a well-structured randomized controlled trial would probably be beneficial to clinicians working in this field of anaesthetics and perioperative medicine. Thank you.
Thank you. Thank you very much. Next up is Roisin.
My name is Roisin. I am currently an anaesthesia SHO at University Hospital in Galway, and this is entitled An Evaluation of the Anaesthesia NCHDs Knowledge of Emergencies in Anaesthesia. So anaphylaxis, malignant hypothermia and IV local anaesthetic toxicity are some of the major emergencies that we come across in anaesthesia. So the Royal College of Anaesthetists have published guidelines outlining the necessity for an anaesthetist to have a working knowledge of how to manage these emergencies. So I suppose the pertinence of this is emphasised when the annual NCHD changeover takes place each year, and new NCHDs are landed into an entirely new environment. So the objective of this project was to evaluate the knowledge of the anaesthesia NCHDs in University Hospital Galway on the initial management strategies of anaphylaxis, malignant hypothermia and IV local anaesthetic toxicity. A 7-question online survey was formulated and distributed among NCHDs. We gathered information on whether they knew the initial dose of the initial drug used in each of the emergencies. They were then asked where they would locate the AGBI guidelines on the management of these emergencies, and then where they would locate the initial drug used in each scenario. So looking at our results, there were 33 respondents out of a potential 40. So looking at the blue graph, this shows the number of NCHDs that knew the initial drug and dose for each emergencies. So all NCHDs knew the initial drug and dose for anaphylaxis. But interestingly, only 40% of NCHDs did not know the initial drug and dose for malignant hypothermia and IV local anaesthetic toxicity. And then looking at the pink graph, so this shows the number of NCHDs who knew where to locate the AGBI guidelines. So 60% knew where to locate them, either on the Galway University Hospital app or in the red folder in each of the anaesthetic machines. And then finally, looking at the green graph here, this shows whether they knew the location of the initial drug. So the majority knew the location of adrenaline for anaphylaxis, but a significant number, around 52%, only knew the location of the dantrolene for malignant hypothermia and intralipid for IV local anaesthetic toxicity. So I suppose in conclusion, there is a deficit in the knowledge among NCHDs of these emergencies. So further education is required in order to orientate people when they first arrive to a new hospital of where the location of these medications are regarding the management of these emergencies. Thank you.
Thank you. We'll see you again soon. Next up is Ricardo.
Hi, good morning. I'm Ricardo Lopez-Betancourt. I'm a researcher at the Memorial Sloan Kettering Cancer Center in New York, and I'm coming to you from Chicago. I'm presenting our study titled Higher Prognostic Nutritional Index, PNIs associated with reduced 90-day post-operative mortality. It has been well established that poor nutritional status is a significant predictor of poor post-operative outcomes. At the same time, while recent studies have shown that up to 65% of patients undergoing major surgery are either malnourished or at risk of malnutrition, only a small percentage of those have obvious signs. This makes it very critical to be able to identify the nutritional status of patients, especially those in the older adult population who are at greater risk of poorer outcomes. For that reason, in our study, we looked at PNI as an indicator of nutritional status. PNI is easily calculated using only 2 lab values, albumin and lymphocyte count. In our study, we did a retrospective review of more than 3,200 patient charts of cancer patients treated at the Memorial Sloan Kettering Cancer Center in New York between 2015 and 2018. The cohort of our patients included those that were 65 years or older, had a diagnosis of cancer, underwent elective surgery at the Memorial Sloan Kettering Cancer Center, had a hospital stay of at least 1 day, and had a preoperative geriatric assessment, which included the assessment of frailty using the MSK Frailty Index. Excuse me. We then divided our cohort into 2 groups, those that had a PNI of less than 40 and those that had a PNI of 40 or greater. We then evaluated the association of PNI in 3 main categories. First, the relationship between PNI and frailty, then the association between PNI and 5 separate post-operative outcomes 30 days after surgery. And lastly, we look at the association between PNI and 90-day post-operative mortality. What we found is that there's a significant increase in frailty in those patients in the lower PNI group compared to the higher PNI group. In addition, we also found that the group of patients with lower PNI has significant poor outcomes in all the post-operative outcomes that we evaluated 30 days after surgery. These outcomes were ICU admissions, readmissions to the hospital, ER visits, major and minor complications, all 30 days after surgery. And additionally, we saw that 90-day post-operative mortality was significantly higher among those with a lower PNI. Lastly, our multivariate regression analysis shows that for every unit increase in PNI, there was a 79% decrease in 90-day mortality after surgery. In conclusion, we see that lower PNI is associated with poor post-operative outcomes and with frailty. And additionally, we saw that there's a significant decrease in 90-day post-operative mortality with increased PNI. Future studies should definitely evaluate if interventions to increase the PNI are associated with better post-operative outcomes. Thank you very much.
Ricardo, thank you very much indeed. Thanks for getting up so early to do that for us from Chicago. Next up is Angharad and Sophie.
Good morning, and thank you for having us at EBPOM Dingle this year. I'm Angharad and this is Sophie, and we're here today to present our poster, which is looking at a survey of anaesthetists' knowledge, skills and attitudes towards shared decision-making at a UK teaching hospital. So shared decision-making, also known as SDM, is core to personalised perioperative care. Multiple studies have demonstrated benefits to patient safety, patient satisfaction and clinician job satisfaction, whilst reducing overdiagnosis and overtreatment. As such, we sought to investigate the current knowledge, skills and attitudes of anaesthetists towards shared decision-making. So we sent an anonymous survey consisting of 13 questions to 143 anaesthetic consultants and 89 trainees at Guy's and St Thomas's Hospital. The questions that we used predominantly utilised a Likert scale with space for further comments where relevant. Content covered understanding and practice of shared decision-making, views on departmental usage of shared decision-making, as well as opinions on incorporation of shared decision-making into anaesthesia training. Our results are shown by the pie charts on our poster. And so we had 61 participants completing the survey, which equated to a 26% response rate. Of those participants, 29 were consultants, with the slight majority of 32, so 52% being trainees. 70% of respondents felt that they had a good understanding of the term shared decision-making, and all the respondents felt that shared decision-making was important to perioperative medicine, with just over 3/4 rating it as highly important. Just over 62% of participants said that they utilised shared decision-making in their normal perioperative assessment, whereas approximately 8% felt uncomfortable using it in their routine perioperative assessment. The overwhelming majority, so 90.2%, felt that shared decision-making should be formally included in UK anaesthetics training.
So in conclusion, our results suggest that the theory of shared decision-making is well understood, but that trainees have difficulty applying this knowledge during perioperative assessments and are interested in improving these skills. From this, we feel that it would be beneficial to include formal teaching on shared decision-making within UK anaesthesia training. Furthermore, we think that a national survey may be interesting to assess some variation in the practice and attitude of anaesthetists towards perioperative shared decision-making across the UK. Thank you very much.
Thank you, Angharad and Sophie. Thank you very much. Next up is Edward.
Morning, everyone. I'm Edward. I'm one of the anaesthetic SHOs in Cork University Hospital. I'm actually pretty new to anaesthetics. I'd worked in medicine up to registrar level previously before changing career. So this was a really interesting case that we saw last month. It was a loop colostomy performed on a patient using Transversus abdominis plane block. This is a local anaesthetic technique because the patient's functional status was very poor. She was a 63-year-old patient who'd been diagnosed with colorectal cancer, and she was unsuitable for chemotherapy. She had limb girdle muscular dystrophy and just had some movement left in her hands. So she had compromise of her respiratory muscles, and there were concerns with the ability to wean her off a ventilator post general anaesthetic. Unfortunately, her colorectal cancer progressed, and she developed developed a vaginal fistula. She was cared for by her husband at home, who had very bad Parkinson's disease, and the care needs were getting worse and worse because of this fistula. There were lots of discussions whether we could do GA on this lady, but her anaesthetic risk was considered too high at that stage. After discussion with 2 or 3 different anaesthetists in our hospital, Dr. Letnan, one of our consultants here, proposed that we do a tap block. So this was performed using ultrasound guided technique. We checked our block that the patient was insensate before incision was made. Our patient chatted to us throughout the operation without any distress. We also infiltrated the visceral areas with xylocaine as well, and this stopped any pain or discomfort that the block wouldn't cover in the abdominal cavity. As I said, the patient chatted away throughout the whole operation, just feeling some nausea when they were forming the stoma and moving the organs around in the cavity, but felt nothing, was sutured up, and went back to the ward perfectly well. So I just thought this was such an interesting case, given that this patient had been completely unsuitable for surgery under conventional means, and the tap block is relatively new, having first been described in 2001. So I think it's worth highlighting that this is an option for patients who require abdominal surgery but are unsuitable for GA. And that's mine.
Edward, thank you, and welcome to Anaesthesia.
Thank you.
So we'll have a chat later. The next up is Harris.
Good morning. My name is Harris, and I'm presenting on behalf of myself, Henry He, Eugene Wang, Emily Belli-Cote, and Jessica Spence from McMaster University in Hamilton, Canada.
Harris, sorry to interrupt, your camera is off, which might be deliberate, but there we go. You please start again, we'll edit that bit out. There we go. Well done.
Good morning. My name is Harris. I'm a medical student at McMaster University in Hamilton, Canada, and I'm presenting on behalf of myself, Henry He, Eugene Wang, Emily Belli-Cote, and Jessica Spence. The title of the poster is Perioperative Benzodiazepine Use and Incidence of Intraoperative Awareness, a Systematic Review and Meta-Analysis. So, just as a background, benzodiazepines are used perioperatively because of their minimal effects on hemodynamic parameters and anxiolytic, sedative, and amnestic properties. And they're also believed to prevent intraoperative awareness and are recommended for such by the American Society of Anesthesiologists for patients at high risk of awareness. So our objectives were to perform systematic analysis and systematic review and meta-analysis to evaluate the effects of perioperative benzodiazepine administration on the incidence of intraoperative awareness. And our overall findings, which we'll get into a bit later, were that the risk of having awareness, which only included 6 trials with events, was significantly decreased with benzodiazepine administration, but the risk of not having awareness, which included an additional 5 trials, was not statistically different between benzodiazepine and non-benzodiazepine groups. So our methodology was as follows. We conducted a systematic review in the context of a larger protocol, which included additional outcomes beyond just intraoperative awareness. So we also looked at things like delirium incidence and duration, post-operative cognitive decline, in-hospital mortality, patient satisfaction, ICU and hospital length of stay, and post-operative nausea and vomiting. We conducted literature searches of major databases, including Cochrane Central, Medline, MBAS, PsycInfo, CIN-AHL, and Web of Science from inception to February 2019 for randomized control trials evaluating the administration of benzodiazepines as compared to any other medication or control in patients undergoing either cardiac or non-cardiac surgery. So 2 reviewers used a predefined eligibility criteria to identify independently and perform duplicate and abstract screening, full text review, data extraction, and risk of bias assessment using the Cochrane Collaboration Risk of Bias tool. If there were any conflicts, they would be resolved by our principal investigator, Jessica Spence, who served as the 3rd reviewer. We pooled trial results using a random effects model. Because of low event rates, we undertook a sensitivity analysis assessing the probability of not having awareness when benzodiazepines were administered. And then we evaluated the quality of evidence using the grading of recommendations, assessment, development, and evaluation, or the grade tool. So our results were as follows. After duplicate removal, we had 26,161 studies to be screened. After that, we had 688 studies that underwent full text review. And after all that screening and review, we included 11 trials that met our eligibility criteria for intraoperative awareness. These 11 RCTs included 1,611 patients altogether, 655 in benzodiazepine arms and 956 in non-benzodiazepine arms that reported on intraoperative awareness. So using the Cochrane risk of bias tool, we judged the risk of bias to be high in 4 studies and unclear for the remaining 7. The overall incidence of awareness across all studies was 3%. The risk of awareness was significantly decreased when benzodiazepines were administered, with a relative risk of 0.37, 95% confidence interval of 0.21 to 0.64, p-value of 0.0004, and an I-squared of 0%. Although this analysis excluded 5 trials with no events. When we considered the risk of not having awareness, all 11 trials were included, and there was no significant difference between the benzodiazepine and non-benzodiazepine groups, with a relative risk of 1.05, 95% confidence interval of 0.97 to 1.14, a p-value of 0.22, I-squared of 94%, and very low quality of evidence altogether. We conducted subgroup analyses to investigate any subgroup differences, including comparisons to dexmedetomidine, higher dose versus lower dose benzodiazepine, and higher dose being defined as greater than or equal to 5 milligram, midazolam equivalent, high versus unclear risk of bias in the study, elderly versus younger patients, and preoperative versus intraoperative versus postoperative administration. And we were unable to explain any observed heterogeneity. So our conclusions are that intraoperative awareness is a rare event, and although it remains unclear whether benzodiazepines prevent awareness, it's unlikely that they have a large effect on this outcome. It is to be noted that the quality of evidence for this inquiry so far is currently very low, and we would recommend further trials with larger sample sizes to investigate the exact extent of benzodiazepines on intraoperative awareness. Thank you.
Thank you very much indeed. Must be early for you there as well. Thank you. We'll have another chat in a second. And I think our final post of this section is back to Roisin.
Hi, so this is entitled an evaluation of the difficult airway trolley and the availability of an emergency cricothyroidotomy set in theatre. So the Difficult Airway Society have published guidelines recommending that the difficult airway trolley be organised according to the sequence of action in terms of management of a difficult airway, so going from Plan A to Plan D. The Difficult Airway Society and the AGBI recommend that equipment be readily available, organised, and that the trolleys not be overstocked. NAP4 also recommended that a means of front of neck access be easily accessible in all theatres, and University Galway has implemented this by having a scalpel, a size 10 scalpel attached to each of the anaesthetic machines. So our main objectives in this audit was to establish if the difficult airway trolleys at UHG comply with the Difficult Airway Society trolley guidelines, and to establish whether front of neck access is easily accessible in theatres. So each of the 4 difficult airway trolleys, 3 in theatre and 1 in ICU, were examined in August 2020 The trolley checklist, stock and overall layout were assessed and was compared to the Difficult Airway Society guidelines. And each anaesthetic machine was checked for a scalpel also. So looking at the picture of our ICU trolley versus our theatre trolley, the ICU trolley is much larger, it's much more easily identifiable, and it follows the most up-to-date guidelines in terms of it follows the sequence of management of a difficult airway. The theatre trolley, although more outdated, the layout isn't incorrect, but it is not identical to the ICU trolley. So the ICU trolley best complied with the DAS guidelines, emulating the sequence of action when a difficult airway presents itself. It was checked daily, it was not overstocked, and all the equipment was within date. The theatre trolleys, on the other hand, were overstocked, they were not checked regularly, and they contained expired equipment, and some equipment such as video laryngoscopes were missing. Of the 16 theatres, only 14 had a scalpel attached to each of the machines. So in conclusion, there's an inconsistency exists between the layout of the difficult airway trolleys in theatre and the ICU. NAP4 states that all difficult airway trolleys within a hospital should be identical in layout so as to promote efficient and safe management of a difficult airway. Following on from this, a discussion was had with the anaesthesia nurses and a consultant anaesthetist at the University Hospital in Galway. And it was decided that the checklist would be, or that the trolleys would be checked more regularly, at least weekly, that the checklist would be revised to include an expiration date component, and that the scalp would be included as part of the daily machine check. So I suppose more importantly, an order has been submitted for 4 new difficult airway trolleys in the hospital to replace the outdated trolleys, and this is being rolled out across clinical sites, so including our obstetric and gynecology hospital and a sister hospital on a different site. So thank you.